Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and this is our 59th show. We are looking forward to next month, where on August 15th we will announce the selected projects to be funded for the Myeloma Crowd Research Initiative. This is a project we started back in January to find and fund research specifically for high-risk myeloma patients. We received 36 proposals and have narrowed it down to 10 and found they are equally exciting for normal or low-risk patients. We started this research initiative knowing that if more patients were involved in supporting leading-edge research, we could find a cure faster, which is what we all want, and it's the first time that patients have been driving the project. The doctors are talented and brilliant, but they need our help to make their research a reality. To show your support today, you can get started by creating your own fundraising page. In a web browser, type in mcri.myelomacrowd.org and click on Build a Team. You can upload your own photo and write your own text to customize your page. And this is a way you'll be able to ask friends and family to support the discovery of a cure for you. So you can take that important step today and be ready for the final projects later next month. Now, we are very privileged today to have with us Dr. Jens Hillengass of the University of Heidelberg. So we welcome you, Doctor, and please allow me to introduce you. Dr. Jens Hillengass is head of the Hemato-Oncological Imaging Work Group in the Department of Radiology at the German Cancer Research Center in Heidelberg. He also serves as deputy chief of the section Multiple Myeloma of the University of Heidelberg and is a attending physician in the autologous stem cell transplantation and multiple myeloma outpatient department. He also serves as head of the Central Blood Withdrawal Unit of the Department of Internal Medicine. Dr. Hillengass is a member of the American Society of Hematology, the International Myeloma Working Group, and the Black Swan Research Initiative of the International Myeloma Working Group. He regularly reviews research publications in Leukemia, Blood, Hematologica, the European Journal of Hematology, and the Annals of Hematology. Dr. Hillengass is the recipient of the Gerock Scholarship from the German Cancer Research Center and the Young Masters Award. So, welcome, Dr. Hillengass.
Jens Hillengass, it's an honor for me to be part of this program. And the first question was on different imaging techniques. And I think it's quite interesting to discuss those because I think during the course of disease, a lot of patients get a lot of information about imaging and out of imaging. And so I think it's important to understand what imaging techniques there are and what they are showing. So I think, first of all, it's important to mention that the different imaging techniques show different or give different information. Of course, myeloma is mostly, the most urgent question is mostly the status of the mineralized bone, like the skeletal bone. And for decades, this information was mainly acquired from conventional X-ray, which is not so bad when it comes to the skull and the long bones, the extremities. But it has very limited sensitivity and specificity for stability of the spine and the pelvis, and there's very important. Those are very important parts of the skeleton, of course. And for this, the problem in pelvis and spine is that there are kind of struts in the spongious bone, which makes the this density higher, and this is a limitation for the X-ray beam, which goes just from one end to the other. And the better technique for this is the computed tomography, which has an X-ray beam going around the body with a detector on the other side, and so you get a 3D information from the whole body and from the bones as well. So this technique, the CT computed tomography, has a higher sensitivity and specificity. Within the International Myeloma Working Group, we are at the moment, together with two very experienced radiologists, are conducting a trial comparing X-ray and CT of patients who had those techniques within 4 weeks. And we want to learn how those two techniques differ concerning the detection of myeloma bone disease. In addition, you can get information from the CT also on the infiltration of the long bones, for example. Not so good in the spine and pelvis, but in the long bones you can see if there is an infiltration of soft tissue within the normally fatty bone marrow in the extremities, in the arms and the legs. but it's not possible to see this in the spine, where it is also very important. So there are other techniques that show the bone marrow itself, where the disease takes place, with a better specificity and sensitivity, like magnetic resonance imaging and positron emission tomography, which are called MRI and PET, as I think you all know. They provide high sensitivity, especially in early stages of disease and after therapy. When we started to investigate the results of MRI, we found that the infiltration patterns are not as we expected for a hematological disease, as myeloma is, to be diffuse. But we found out that there are also focal accumulations of plasma cells, of malignant cells, all over the bone marrow, and we found that those focal lesions and also the diffuse infiltration pattern were present in about a third of the patients each, and the combined pattern, like mixed pattern of diffuse and focal infiltration, in again about a third of the patients. And we found out that those lesions can be of prognostic significance, either before therapy and also in early stages of disease, as well as after therapy. The problem for MRI is that after therapy you still have those lesions left. For example, when there is an osteolysis, it will not go away after just 6 months or something when the treatment has finished. But there will be still residual lesions, and we don't know if they are really containing vital cells, or if they just are scars or osteolysis left there without vital cells in them. So in this case, PET-CT comes into play, because PET shows the metabolism of the cells investigated in this region, and it correlates quite well with the activity of the disease. So in summary, CT and X-ray are very good for diagnostics of the mineralized bone, and CT is better than X-ray to our knowledge, and PET and MRI are more able to display bone marrow. So next question on the patterns of the lesions. As I mentioned, we have some patients with diffuse infiltration, some patients with focal infiltration, not really knowing what that means from a biological point of view, but it's kind of, as I mentioned, regular distribution all over the patient groups, with some patients having focal lesions, some having diffuse infiltration patterns, and some having a mixed pattern, or even a normal pattern, like normal bone marrow in other not malignant diseases, for example. And there have been several studies on the prognostic significance of those patterns, and it was shown that the diffuse pattern, especially in the symptomatic patients, have the most adverse prognostic significance, and focal lesions are also not very good, because the more focal lesions, of course, the more tumor mass you have, and those are also of adverse prognostic significance. And the normal pattern seems to be of best prognosis for the patient who show that. As I mentioned also, after therapy, if residual lesions, especially in PET-CT, remain, it's also an adverse prognostic factor, because it has been seen that those focal lesions might be the source of a relapse of the disease after treatment, if they reside after completion of the therapy.
The patterns of lesions are important, I think. Mm-hmm. So if you could continue what you were saying in explaining the different patterns and how those, how we can see those on the MRI, and what those mean.
Mm-hmm. Okay. Those patterns, it actually in the beginning was kind of surprising, because we thought, okay, maybe it's a because we know myeloma is a hematological disease, it's a systemic disease, maybe the cells are just thrown all over the bone marrow. But then we found those mentioned different patterns, like diffuse infiltration, as we expected, but also those focal lesions. Of course, we knew that osteolysis are a typical symptom of multiple myeloma, showing also the circumscribed destruction of the bone. But it was still surprising that there are those different infiltration patterns, and some patients only have one pattern, some have different patterns. And so we investigated, or we're actually at the moment we are investigating and comparing those different different patterns, and found, we're looking for the different maybe genetic background of the focal lesions. So we are doing CT-guided biopsies of focal lesions, and we compare it to the random bone marrow sample as we do it in every patient at first diagnosis. And we want to learn if those cells are really different, because some of them grow focal and some of them grow in a diffuse pattern, and to see how those differ, and if this is really from a biological reason why they are growing focal or diffuse. And as well, there are patients with both. So there seems to be some difference in the phenotype, like what we see, and maybe there's also difference in the genotype, but we don't know that yet.
So when you describe it as focal lesions, which I think we're all pretty familiar with because those show up even on the x-rays. Mm-hmm. And then can you further describe, because maybe I missed this when I was trying to get the technology to work, the diffuse infiltration, or what you define that as, how that shows up, what it looks like, and then the salt and pepper pattern that you were saying.
Mm-hmm. Yeah, this diffuse infiltration is it's very difficult because it really takes an experienced radiologist, because the diffuse infiltration just is so-called hypo-intensity in one-weighted imaging. There's T1, T2 for the radiologists in this audience. T1 and T2, and they show different, they are different weighted. They show rather a fatty content as a hyper intensity, or a water content as a higher intensity in the images, like higher intensity meaning brighter color or brighter gray. And this diffuse infiltration is shown has a higher water content because there are more cells. It's a higher cellularity, and you can compare this gray scale you get out of the MRI image. Usually you compare it to the intervertebral disc, because the intervertebral disc usually has the same gray scale, gray color, and so you compare this. And if it's darker or hypo-intense compared to the intervertebral disc, it's a high infiltration, and if it's lighter or lighter than the intervertebral disc, it's a lower infiltration. And this, you mentioned the salt and pepper pattern. This is also something we not totally have understood that, because it's mainly found in older patients, but not only. And it seems to be, we compare it with histology, but it's not easy because histology is very small, because you have the microscopic view, and the MRI is like the whole body. And so we compared it, and we think that it displays very small lesions, small focal lesions on a background of a fatty bone marrow. Fatty bone marrow is normal in older people, because over the years the cellularity goes down and the fat content of the bone marrow goes up. This is very normal and in a physiological process over the years. And so we are interested in those different patterns with not knowing at the moment if there are really biological differences. We found out that from a prognostic point of view, the salt and pepper pattern is nearly the same as patients without visible infiltration in the MRI, and we don't know why some patients really look like a healthy control in the MRI but still have a myeloma. We are also looking into that. But those patients with a normal or a minimal infiltration and the salt and pepper pattern have a quite good prognosis, while the diffuse, really diffuse, high diffuse or severe diffuse infiltration plus the focal lesions, those patients have a little bit worse prognostic factor in this imaging point of view.
So I don't think I'm understanding the difference between the diffuse infiltration and then the salt and pepper pattern.
Mm-hmm. The diffuse is a really homogeneous. If you look at we usually use the spine. We look at those vertebral bodies, and we see it's a homogeneous gray scale of the same pattern. And if you look in this salt and pepper, it's rather a light background with some very small, like salt and pepper mixed, like you mix a dark and a white granular. and they are like thrown into this background of a quite high intensity, like high or light color. So the grayscale homogeneous is the diffuse infiltration, and the salt and pepper is just small islets of dark in this white or fatty background.
Okay, so that makes a lot of sense. Mm-hmm. And then when you say, so I guess the next question is a little bit of what you covered, I think, at the beginning, is what the MRI provides that the other tests can't.
Yeah.
The X-rays, everybody does them, but they are not terribly useful, from what I understand.
Yeah. So X-ray is really showing the bone, the mineralized bone, because there's nearly nothing to see concerning soft tissue involvement, concerning involvement of the fatty content in the long bones, where you can see in CT, for example, if the fat content in the long bones, where you can see really a dark background with light infiltration in the CT images, this is not visible in this X-ray at all, because the sensitivity is just too low. So we have those long bones, and you can see in the CT that infiltration of the long bones. But in the spine, there is the spongious bone with a lot of trabeculae, those small parts of bone, and so the density is quite high. The CT shows this like a sponge in the images, but you are not able to see the bone marrow within those small pores of the vertebral bodies. And you can see this very good in the MRI, and those different diffuse infiltration patterns we just talked about are very well seen in the MRI. A lot of people ask why use MRI when we have PET-CT. So for the PET-CT, we have the CT part, which I mentioned is quite good for the mineralized bone, but and the PET part is quite good for the bone marrow, where the actual disease takes place, because there are the plasma cells. But MRI has a high sensitivity, especially for this diffuse infiltration. As I mentioned, the diffuse infiltration is the most adverse prognostic factor from an imaging point of view. PET is very good for focal lesions, especially after therapy, because if there is still an uptake of this nuclear tracer, you can see this that there are still vital cells, which you can see in MRI. So the main benefit of MRI is early detection because of the high sensitivity for the bone marrow, as well as the detection of this diffuse infiltration. Because in PET-CT, it's not very easy to really assess this diffuse infiltration, because sometimes it's just a reactivation of the bone marrow. It could be inflammation, whatever. So for focal lesions, PET and MRI are good, but for the diffuse infiltration, MRI is a little bit better, and especially in the early stages of disease like smoldering myeloma.
Well, I know we have smoldering myeloma listeners that will probably ask some specific questions at the end that are always excellent. And I wonder if the doctors doing the initial diagnosis, now I know this is probably a question for later, but when you are diagnosed, typically you're not going to see a myeloma specialist for that diagnosis, which is an issue, because sometimes they'll do the X-ray and then they'll do a bone marrow biopsy, but they sometimes, in many cases, won't do an MRI or sometimes even a PET-CT scan. So do even myeloma specialists know about the value, I guess, of the MRI as much as you would like?
It's always interesting when I give talks on imaging, obviously, but also talks on other topics, and especially the new guidelines which include MRI. It's surprising how few doctors are really, I don't know if interested, but really informed about the benefits of MRI. I think if you have osteolysis in X-ray, everything is clear because you have crack criteria and you have to be treated. If you don't have osteolysis in X-ray, you don't know if you still could have infiltration or osteolysis even in CT, because CT shows also very small osteolysis, which are not shown in X-ray. So CT is even beneficial compared to X-ray. And we actually, in our clinic, we changed from X-ray totally to CT. We have a whole body low dose CT, which has a little bit higher radiation dose than X-ray, like 2 to 4 times, but still it's quite low and doesn't need any contrast agent. So it's very easy for the patient. It's like 3 to 5 minutes. They just lie down, go into the machine, come out, and we have a whole body CT with a very high sensitivity. So this is quite easy, and as I mentioned earlier, we have at the moment we have a study going on within the International Myeloma Working Group with a lot of participants from all over the world sending us CDs with computed tomography and X-ray of patients at first diagnosis without treatment, and we want to compare them and see how much more is the sensitivity or how much better is CT compared to X-ray, because every radiologist you talk to, they say there's no question that CT is better than X-ray. They say it's obvious and everyone knows that, but maybe not every hematologist. So my first thing I want to mention is that CT is quite superior to X-ray. But furthermore, if CT is negative, the number of patients with this is getting smaller and smaller. So if you have X-ray positive, it's obviously osteolysis, you have to be treated. If CT is positive, okay, also osteolysis, we can discuss if they are very small, if we should already treat. And then the next step is if CT is negative, we can do an MRI, and if the MRI is positive and shows focal lesions, more than one, according to the International Myeloma Working Group criteria, now is called treatment eligible or treatment necessitating multiple myeloma. At the moment we are discussing a lot about this issue, because if the radiologist is not really experienced, there might be some spots in MRI which are not really myeloma, and those patients should not be treated because they are still smoldering. So it's at the moment it's a little bit an issue to train, on the one hand, the hematologists to really think about MRI and to think about early detection, and on the other hand, the radiologists who don't see very, very many myeloma patients. We have, for this study I just mentioned, we have the most experienced radiologists seeing like 10 to 20 myeloma patients per day in their practice. But if you see one myeloma patient in 1 or 2 years, it's not easy to really differentiate. So those also the radiologists, and the radiologists in our study are very interested to train their colleagues to learn how myeloma looks in MRI and what we can get out of this information. As I mentioned, if X-ray is positive, CT is positive, it's already crack criteria, no problem. But if MRI is positive, you really have to look carefully if this is really myeloma. You will not get the absolute answer, because the absolute answer would be putting a needle in and get some cells out. But on the other hand, I think it's important to know that there can be focal lesions in MRI which not have led to osteolysis at that moment. So it could be MRI positive and CT negative.
Yeah. Interesting. Well, it sounds like it's scaled, with X-ray being the least sensitive and MRI being the most sensitive.
Yes.
So maybe you'd like to tell us how the MRI technology has changed over the last few years to be able to do that, because this wasn't typically part of the, as a key part of the diagnostics, was it?
Mm-hmm. Mm-hmm. No, it wasn't. It was just, I think we started to do any MRI in myeloma in 2004 something, and then we found those different patterns. They were already published, because first MRI papers on MRI in myeloma or monoclonal plasma cell diseases were published in the 90s, even in the 80s. But it was the image quality was very low. So you saw something, but you didn't know what, and the first publications on prognosis and on significance of MRI were just if MRI is positive, like meaning, I don't know, doesn't look normal. So those were the first steps. But with the newer machines, with a higher field strength, like more Tesla. This is the unit you measure this. With newer machines, newer scanners, you get better quality, you get faster investigations. But I have to mention that MRI still takes a long time. It's the longest technique you can come for with multiple myeloma. Takes at least 30 to 60 minutes. But with those new scanners, you get really good information on the bone marrow. Again, mentioning bone marrow, I have to admit, MRI doesn't show the mineralized bone at all. There's just a black where the mineralized bone is, but you can very good see the bone marrow and see those infiltrations. So for the assessment of bone, this is another issue. For the assessment of bone and bone stability, you still need an X-ray based technique, and we use CT, and I would also recommend to use CT if available. So MRI really improved in quality, and it came to a certain quality where it was really useful, or now it is useful for myeloma patients. And as mentioned earlier, especially in the early stages of disease, because there you don't have osteolysis, and as X-ray is negative, maybe CT is negative, but still MRI could be positive, and you can see if those lesions are there, if this diffuse infiltration is there. And then we did a comparison of follow-up MRIs. We did MRI every 6 or 12 months in smoldering myeloma patients. And it was interesting that if there were focal lesions in the beginning and they didn't change, it was not really an adverse prognostic factor. But if they grew, if the size increased, or if the number increased, if they had 1 and then 3 and then 4, whatever, they had a very early progression into symptomatic disease. So we think, we cannot prove that, but we think that osteolysis are osteolysis are preceded by those focal lesions in MRI. So there are those accumulations of plasma cells leading to those focal osteolysis, causing then fractures and pain and so on.
Well, that leads me to a follow-up question. I guess how often, that's one of the questions, maybe it's for later, but how often should patients be having some of these? Because I know in some facilities they alternate. They'll say, okay, here's the 6-month check, we'll do a CT, this next 6-month check, we'll do an MRI. Yeah. And some of it's based on what your insurance covers. Yeah. But, what they will approve or not approve. But what do you believe is valuable for both smoldering or MGUS patients and fully active myeloma patients? Yeah.
We've thought about that very, very much, because it is an economic question, of course. Each imaging costs for the patient or for the insurance or whoever pays. So we really thought hard about when are the most important time points. And we decided in our daily practice to do an MRI. We have the possibility to do a whole body MRI. I think if you have a whole body CT or a whole body PET CT, of course, then you can maybe stick with a spinal and pelvic MRI, so an axial MRI. But we can do a whole body MRI, so we do a whole body MRI and a whole body CT at first diagnosis in every patient, mainly in smoldering and symptomatic, but sometimes also if there are suspicious lab values, also in MGUS patients. So we have one point where we do nearly everything, so CT and MRI. We have in Germany the problem that PET CT is not covered, so in symptomatic patients I also would recommend a PET CT and an MRI. So have the MRI mainly for the bone marrow and the diffuse infiltration. You have the CT and the PET CT for the focal lesions and for the osteolysis. And for follow-up, we do, because we don't have PET CT, after therapy, if a patient has achieved a good deep response, then we do again an MRI. I would like to do a PET CT, but it's not covered in Germany, so I do an MRI, because it also gives me information, mainly if the diffuse part of the infiltration has disappeared, which is mostly the case. And we also look if the number and the size of focal lesions has decreased. But as I mentioned, the problem in MRI is that there still will be focal lesions if there were osteolysis, because osteolysis does not heal within 6 months. It takes much longer. Even we thought that osteolysis of myeloma patients never heal, but then we started to do CT, but this is another topic. But we started to do CT and did CT after therapy. We do that also after therapy, and we found that at the margin of the osteolysis, sometimes the sclerosis appears, and this seems to be a kind of a healing process, and we only see this with the novel agents. We never saw this with melphalan prednisone or VAD and high-dose therapy. There was no change in osteolysis, but when we started to use bortezomib, lenalidomide, and all the new agents, we saw that there is, combined with bisphosphonates, of course, there is a kind of, in some patients, a start of healing of osteolysis. And this is also very important information we get out of CT and also of MRI, that there seems to be kind of a healing of those focal lesions, osteolysis, and bone marrow infiltration. So to summarize, we do it at first diagnosis, we do it after therapy, and we do it, this might be a lot, but we do it once a year in every smoldering patient, a whole body MRI. We do a MRI and a CT in the first diagnosis to exclude osteolysis, which would be myeloma, and exclude more than one focal lesion, which also would be treatment requiring myeloma. But we do then in the follow-up just once a year an MRI. And we also do it in oligo or asecretory multiple myeloma, which is not very often, but I just collected some patients. I think we have about 50 patients over the years with an oligosecretory or asecretory multiple myeloma. And there the whole body MRI is very useful because we can detect changes in lesions, like growth in lesions or increase in number of lesions before there is any serological or any bone marrow change. If we do a biopsy. So we spare biopsies by doing more MRI in those asecretory or oligosecretory multiple myeloma, but those patients are rare.
And these are patients that are not secreting the M spike, but still are having
right.
They still have active multiple
Correct.
myeloma.
Yeah.
So
it's very rare, but there are some patients, especially after some lines of therapy in the further course of the disease, in the later course of the disease, there could be this asecretory or oligosecretory type of myeloma. Yeah.
Mm-hmm. And maybe we want to go back a little bit and explain what else the MRI can provide that the other tests cannot. So I was reading your recent paper in Hematologica, and it mentioned things like spinal cord or nerve compression, or benign versus malignant fractures, or bone plasmacytomas, and things like that. Are there other things that the MRI can detect?
I think those that you mentioned are very important, especially this benign versus malignant fracture. It's not an absolute yes or no, but if you, as I mentioned, in an older patient, the bone marrow is replaced by fatty tissue over the years. This is normal. This takes place in everyone. But if there is an infiltration of, for example, myeloma, this bone marrow, this fatty bone marrow is replaced by the malignant cells. So you have, again, a higher cellularity. So if you have an older patient and you have an osteoporosis, which is not uncommon in older, especially in older women, postmenopausal women can develop osteoporosis. So if you have an osteoporosis and a small M spike, you don't know if it's an MGUS plus a benign osteoporosis because of postmenopausal situation, or if it's really a multiple myeloma with a small M spike but infiltration. And there we can use, if there's a fracture, for example, we can use the MRI to compare a fracture with a high cellularity, which would be expected in a malignant process like multiple myeloma, or with a low cellularity, which would rather point to a benign cause of the osteoporosis like postmenopausal age. So this is very useful to use this MRI. It's not very often, but of course an older MGUS patient will always have this question. If he has osteoporosis, is it caused by hormonal changes or by the infiltration of a malignant disease like multiple myeloma? And you mentioned something else I thought important. The spinal cord compression. This is very important. I think it's I know it's the technique of choice for the neurologists and the orthopedic surgeons if they have if there's suspected cord or spinal compression after fracture, for example, or if a soft tissue tumor grows into the spinal canal, then MRI is the best technique to show this, because you can see the nerves, you can see the spine, the vertebral bodies, and you can see if there is a tumor or if there's a fracture causing this injury of the spinal cord. Yes.
Interesting. Okay, now let's go over, you touched on it just a little bit in the beginning, but let's go over your paper and how you are using imaging to score patients and predict outcomes. So you mentioned, the diffuse and things, but if you could kind of review it for us, that would be, or spell it out for us, that would be great.
Okay, of course. I mentioned now several times the diffuse and focal lesions. It's easy to count focal lesions. It's kind of a lot of work, because when you have whole body imaging, you have a lot of images. The radiologists are not very happy to see that many images, but they accept it. And so you can count those focal lesions. And we know the more focal lesions, the more tumor mass, the more treatment is, the more urgent the treatment is. If you have symptomatic patients, there was a very good paper from the Little Rock group from Arkansas, and they compared patients with more than 7 focal lesions. That was spinal MRI at that time. It's quite old paper already. Spinal MRI, focal lesions more than 7, 3 to 7, and less than 3. And they found that if you have more than 7 focal lesions at first diagnosis of symptomatic disease, even with the most aggressive treatment at that time, total therapy, so-called total therapy, they had an adverse prognostic significance to have those many focal lesions. So it's of prognostic significance, the numbers of prognostic significance in symptomatic myeloma. We looked into smoldering myeloma, found nearly the same, but the cutoff calculated by a statistician was more than 1 focal lesion, which might be a little bit too few focal lesions as a prognostic factor, but still this was what we found, and it was confirmed by another group. So this number of focal lesions is of prognostic significance in all stages of disease, actually. And this diffuse infiltration was also found that if it's present, it's an adverse prognostic factor. So we thought, why always do this diffuse and stop, and then do the focal counting and stop? We wanted to compare, and again, our very good statistician looked into that, and so we found kind of a score combining the diffuse infiltration, like severe diffuse infiltration, moderate diffuse infiltration, salt and pepper, as we mentioned, and minimal infiltration, compared or in combination with the number of focal lesions. And we have this score that is mentioned in the paper. So we have the information, the whole information from the MRI, and put it into one score. And you can score as like in other scores. You can score 1, 2, 3 in different groups. So the more focal lesions, the more severe the diffuse infiltration, the worse the prognosis. And if you have very few focal lesions or no focal lesions even, and very few diffuse infiltration regions or a very low infiltration, then you have a better prognosis concerning imaging. We haven't compared it yet to the other very important prognostic factors, but we found, this is not published yet, but we found that there is a correlation of more focal lesions with, for example, high LDH, which is also a prognostic factor, and with high-risk cytogenetics. This correlation was very weak with the cytogenetics, because I think a reason for this might be that cytogenetics rather show the biology, the genetics of the plasma cells, while the MRI more shows kind of the tumor mass all over the skeleton. So there is a very weak correlation, but I think it's also a positive information, because we have additional information out of the imaging, not only repeating what the cytogenetics already tell us.
So I know that you're saying that high LDH levels are a known high risk factor, and then high risk cytogenetics like a deletion 17 or 14, 16 or something like that. I've heard someone say, now I can't remember who, talking about how there could be more bone damage, but kind of a slower growing myeloma, if that makes sense, even though it might be a worse prognostic factor. Can you address that at all, what you've seen from an imaging standpoint?
Yeah, that's true. We have some patients. I have no really certain explanation for this, but if there's a slow-growing myeloma, there can be a lot of osteolysis before there's any pain or before there's any fracture. So the patient can already have the myeloma for a very, very long time without symptoms. But then if you have the diagnosis, maybe if the first fracture appears or occurs, then you have the diagnosis because the patient goes to the doctor and the whole diagnostic machinery is going on. And so we know there's the myeloma, but it could be that the myeloma has been there for a very long time earlier, but we didn't see it because we haven't looked for it. So this could be a reason why some patients, I just saw on Monday, I just had a patient I know for several years now, and he has a very, not benign, but very slow-growing long-term myeloma, which responds very well at the moment, to lenalidomide. It has, I think, several years now on lenalidomide, but he has very, very severe osteolytic destruction of the bone. I think it was not because the disease was very aggressive, leading to very fast and bad destruction of the bone, but it was a very slow-growing myeloma, which responds to the therapy now, but still he has those destructions from the time when we didn't know that he has myeloma, and the myeloma already destroyed his bones, and then there came the first fracture, and then he came to his doctor, and then the diagnosis was made. So I think that could be an explanation. And I also think it's not always true that a high tumor mass must be an adverse prognostic factor. It also depends a lot on biology, cytogenetics, and so on. I think it's always important to see the whole picture, not only look at the imaging, not only look on genetics, not only look on clinical parameters, but see the whole picture. And I think this is very important to really get an impression what the prognosis, the real prognosis of the patient is. We still see patients with deletion 17p, which usually should have a bad prognosis, but still live for a very, very long time with their disease, and we don't know why this is. But I think it's more complex than just say this is a factor. It always leads to this and that outcome.
And so you're saying you're just barely beginning to say, okay, now that we know more about what the MRI can provide and the number of lesions and the diffuse lesions and the patterns, then now we can match it up potentially with the genetic features and see if there are patterns that kind of cross over one another. Correct. And you're just at the beginning stages of doing that?
We started, and there is one publication from a Greek group, and they compared MRI findings with genetics, and there was actually, I think, no or very, very, very low correlation of genetics and MRI findings. We did it with functional MRI, which measures functional processes like microcirculation, perfusion of the bone marrow with contrast agent, and we had quantitative parameters of this microcirculation, and we found that there was a correlation of a high microcirculation, meaning a lot of blood vessels in the bone marrow and a lot of very destroyed blood vessels which are not very functional anymore, and those correlated better to deletion 17p and 1q21 again, and so there was a correlation of, in this case, a rather functional and biological information, but just the morphological information, just a lot of plasma cells in MRI, does not mean that it's also bad cytogenetics. So I think there's more to this than we know at the moment.
Oh, yes, I think there is, but people like you are working on it, so we're very hopeful. So a couple more questions. Is the placement of your lesions predictive at all or important at all?
After therapy or the placement? Okay, sorry.
Yeah, like where they're located, in your spine or in your hip or wherever. Mm-hmm.
I think there's two ways to look at this. As if you say, if it's located in the spine, in the rib, in the pelvis, in the extremities, whatever, we found no correlation or no prognostic information out of the location within the body. What was interesting, or what is interesting, and what is quite well known, is that if the location is inside or outside the bone itself, like if it's in the bone marrow or if it's coming out of the bone, going through the cortical bone into the soft tissue, and the third being just in the soft tissue without connection to the bone is, of course, of prognostic significance, because we know that myeloma cells are very dependent on the microenvironment which they find in the bone marrow. And if they are quite advanced in their malignant development, they also are sometimes able to develop within organs or soft tissue. And so if you in MRI or PET-CT find focal lesions in the soft tissue alone, this is a very bad prognostic factor. We don't see this very often at first diagnosis, but sometimes after several courses of disease, there are also appearing soft tissue tumors in myeloma patients, or like in the skin sometimes. And this is a very bad sign actually for multiple myeloma patients. So it's the location concerning the bone is very important, inside the bone, outside the bone, with no connection to the bone. But if it's in the skull or in the pelvis or in the spine, to our knowledge and into our data, is not important at all. It's just important for, of course, stability. Like when the spine is infiltrated, it's worse than if there's a finger or whatever. Yeah.
Okay, well that makes a lot of sense, and it means maybe the myeloma is just escaping, and then you can't, lock it down to the bone, right?
Maybe, yes. Yeah.
Are there other factors that contribute to overall survival? You mentioned the high LDH levels, or in your paper you mentioned being, stage 3 or later. Are there other factors beyond those things that are contributing as well?
In our study, this was focusing on MRI, obviously, but the correlation with LDH and, as you mentioned, with ISS, a high ISS stage, also correlated with the imaging with a high infiltration, high tumor mass. This was well known, but I think it's interesting to get it confirmed by this imaging. So imaging really correlates to the tumor mass, and ISS correlates to the tumor mass, and both is a prognostic factor. I think in our paper we found no other factors than the already known, like cytogenetics and ISS, but they were confirmed in this group of patients.
Oh, okay, perfect. And let's talk about treatment a little bit. When you are doing MRIs after treatment, first you mentioned a little bit about the bones being able to heal in some of the other therapies. So how long do bones take to heal in general?
And this is an extremely interesting and very often asked question. Of course, my patients also want to know, when can I do my sports again or exercise or whatever they like to do. This is very important, but I cannot really answer it right now. We have seen after the first changes, the first positive changes to a better in CT was, I think, 6 months after initiation of therapy, but this is very, very early to really have significant changes. And we want to look into that. We haven't done it. We want to look how long it takes. I think it takes years and years, because the bone is already damaged by a malignant disease. The first step is to eliminate the malignant disease, like myeloma, get the deepest response possible. But I think now we can look into patients who have been on long-term complete remission, but they were treated 5 or 6 or 10 years ago. So those are the long-time survivors, and we can look into them, but they are not treated like the treatment today. So we cannot say now what will be in 10 years. So this is kind of a complicated trial to do, because we always have to see patients after several times. We are aiming to do a study doing imaging after a long remission, but we don't have very many patients right now because they were treated with the old drugs with only only high dose. So I think it's very important and very interesting, but we cannot answer this now because now the patients get those very new and very effective treatments, and we will see in 5 and 10 years what the bone changes are over time.
And then what more can the MRI tell you about the myeloma when you take it before and after transplant? What are you looking for in the changes? Just the pattern changes or the quantity and what else?
Yeah. It's interesting that the diffuse infiltration usually in every patient changes to a normal or minimal infiltration pattern. So the degree of infiltration goes down if the patient responds to therapy. If not, it stays the same. But it goes down. It correlates with very well with the serological parameters of remission. The number of focal lesions, if there were no osteolysis, also go down. But as I mentioned, in MRI you cannot see if there are vital cells, so there is still a lesion, but this lesion could be just dead cells or necrosis. So this is a limitation, obviously, of MRI. And if there's osteolysis, you just see the focal lesion still. While not seeing the bone in the MRI, you still see the osteolysis with this focal lesion left there with some fluid in it, or there's just nothing. There's still a lesion. So we look especially in the diffuse infiltration pattern, but also in the focal lesions. And if they really disappear, it's a good sign. If they don't disappear, it doesn't really tell you very much because you don't know if those cells in those focal lesions are really relevant and vital anymore.
And you've made me intensely curious to ask my doctor about my diffuse lesions, if I have any, because I got a count of focal lesions, but I think unless patients are asking questions like this, they never really review it. Is this something a pathologist? We had a show where a pathologist said, you should pull your pathologist aside and ask them to go over your records with you because they're happy to do it. Is this something a pathologist would go over with you, or is this something that you should really have your doctor review with you, or while you're in the clinic, take a look at the screen and see the difference?
The hematologist or even the radiologist, because they are the experts for changes in MRI. So in our clinic, we have a tumor board where we demonstrate myeloma patients. And as I mentioned, because we have a lot of patients, we have a very experienced radiologist, and he discusses a lot. He says, okay, there's a change with that, and this lesion is disappearing. And sometimes even new focal lesions appear because the formerly diffuse, as I said, there is a mixed pattern sometimes, and sometimes the diffuse infiltration is so high that you don't see the focal lesions under this diffuse infiltration. And if the diffuse infiltration goes away, it could be possible that focal lesions appear which have been there earlier, but you haven't seen them because there was this high diffuse infiltration. This is very rare, but even this can be told by experienced and good radiologists. And they should be trained to see myeloma or at least hematological diseases, because it's quite difficult. And there's another thing to mention, especially in young patients. A young person, as I mentioned, already has a higher cellularity in bone marrow without myeloma. And we did comparison with healthy controls, and the young patients looked like an older patient with a diffuse infiltration, but it was just the physiological hematopoiesis, the bone marrow producing the cells which is higher in myeloma, which is higher in younger patients, in younger controls, and so it's also tricky to really look into this diffuse infiltration. We are working on functional techniques which can really measure the cellularity, but still you cannot differentiate if it's just a lot of plasma cells or just a lot of healthy bone marrow cells. So this is still a topic to be addressed. Yeah.
Okay, it's so fascinating, and we're going to keep you late if you don't mind because we got a late start. So I hope that the callers will, because I know they have questions, will hold on with us too. But you, in your paper, you were talking also about different therapies that patients were on a variety of therapies. Did you see a difference between the type of response with therapy? Is it giving you any indication about which therapies might be more effective?
Not beyond the point where we already know that some therapies are more effective than others. We just saw the more effective therapies were more effective in serological markers, but also more effective in imaging. So it's not really additional information we get out of the imaging concerning the depth of response. We just can say what is interesting, if we have residual lesions, it might be that if a patient is in a serological CR, no M spike, no light chains in urine, no free light chains, maybe not even plasma cells in bone marrow anymore, but if there are still focal lesions outside the pelvis where you do the biopsy to confirm the complete response, it could be that those focal lesions are still relevant and could be the source of a relapse later on. And this is also an important topic we are aiming to answer in this formerly mentioned study on the CT-guided biopsy. We will do again a CT-guided biopsy if we have residual lesions after therapy in our patients and see if there are still myeloma cells in there, and maybe those patients would benefit from a maintenance therapy or a local therapy or whatever. We cannot do this in one step, but this would be topics to be addressed in the future. And we do this CT-guided study, and we are really grateful that our patients are accepting this study, and they are contributing by being available for the CT-guided biopsies.
Well, a follow-up question to that is, would it be helpful, because you're specifically studying MRIs, would it be helpful at all if patients around the United States or other countries just sent you copies of their MRIs? Or do you really need to do it in a more, in a more smaller setting in your clinic or in Germany or wherever?
Yeah. That's true. The problem with that is that there are, in Germany, the ethical and the data security agencies are very strict, which I find quite good. And it's not, for us, it's not able just to get a CD from a patient and then do an examination. And furthermore, the techniques are different, sometimes a little bit at least. The scanners are different. Maybe there's another sequence of MRI when we do it. So at the moment we are doing mostly examining our own patients, because we have a lot of patients. Number is not the problem. It's rather time and the money to pay a radiologist to do the examination. We have thousands of MRI images, but not a lot of radiologists who are willing to sit there hours and hours and do the evaluation. But we are working on this, and we have really motivated colleagues. And so it's not what we are aiming for, and we already discussed this with colleagues from other countries and also from the US, to do an examination in our patients and then use this, for example, this score you mentioned earlier in the paper, and put it on another group of patients in another clinic, for example, in the US or in France. We discussed with colleagues from France, from the US, from Greece. So other colleagues having MRIs of myeloma patients at the same time with clinical information. Then we send them our results, and they look if those results really are the same in their cohort. And this is very important, but I think it's more important to do this within big centers. And if the patients are willing to get their imaging results reviewed, they should go to a myeloma center. And as you mentioned, I think it's important that at least once in his or her career of myeloma, being a myeloma patient, everyone should have been seen really myeloma doctor specialized in myeloma treatment, because it's so complex. It's so complex to have those imaging techniques, those cytogenetic results. It's really complex to do myeloma. I'm doing only myeloma. I will not treat any other tumor at the moment because I'm not specialized in this. And I think myeloma is so complex that we really should aim to have specialists for myeloma.
Oh, I'm such a huge advocate for that, and so are all the patient advocates that I partner with, because there's just too much. You just can't know enough about that. I mean, you think about the complexity that you're trying to deal with. Even just, do these genetic features match up with what we're seeing on the MRI, match up with like a high LDH level and maybe a low albumin level or something like that. And you just think, wow, that's just too much for my one brain to figure out. So that's just and it's very complex, and we strongly advocate all the time that you need to see a myeloma specialist. You can always get treated, your weekly infusions or monthly infusions.
And I think most of private
else.
practice doctors are very motivated to send the patient once and get some advice, and then they do a very good job, of course. This is not saying that the private practice doctors are not good enough for myeloma, but it's, as you mentioned, it's so complex, and we can help each other. I would never question what they decide, but I can give an advice from my experience with a lot of myeloma patients. I think this is very, very important, and to my knowledge and to my experience, a lot of private practice doctors are really happy to collaborate and to say, okay, this is my patient, what would you do? And then I say, this is what I would do. And then they decide, and they get a very good decision, come to a good decision overall. And I think the collaboration is very, very important. And we cannot treat every myeloma patient. It's just too much. But we can support those people who are doing the work there.
Well, I want to open it up for caller questions just so we have time to do that. So let me say that if you have a question for Dr. Hillengass, you can call 347-637-2631 and press 1 on your keypad, and we also have some emailed in questions. So we'll start with our first caller at 983-6757. Go ahead.
Good morning, Jenny. Good morning, Dr. Hillengass. This is Dana Holmes. I'm so very happy to speak to you today. I'm a smoldering multiple myeloma patient, so I have a bunch of questions that I hope that you'll be able to to answer for me. I guess my first one I want to start out with is related to MRI reports in general. Are we looking for the term related to marrow signal within the report, that being within normal limits versus a diffuse signal, or terms like focal lesion? What kind of would signify to us that we have an abnormal MRI reading related to myeloma? What terms do the radiologists use?
Very good question, and I think it's important for patients to know what to look for. It's still difficult, and we just discussed how difficult it can be to treat myeloma and to diagnose myeloma, but I absolutely recommend that you look for those, as you said, those specific words, and I would say focal lesion is one important word, and of course this diffuse infiltration. I think signal intensity can be misleading because it can say everything and nothing. But most important is focal lesion and diffuse infiltration. But even there, it has to be you have to be cautious, because sometimes a diffuse infiltration, if it's not a very experienced radiologist, or if he or she does not have the proper information, it might seem like a diffuse infiltration, but it's just an increased cellularity because of an overactivation of bone marrow. So sometimes we get patients referred to us with a multiple myeloma question mark because of diffuse infiltration, which is not true. If you put a needle in, it's just a normal activated, for example, by inflammation, by infection, whatever, activated bone marrow. So focal lesion should be quite differentiating, but also there could be focal lesions which are just hemangiomas, which are benign tumors without any significance. So look for focal lesion, look for diffuse infiltration, but do not be shocked if there is something written like this. Let your doctor look at it and look if it's really a myeloma-related focal lesion, or if it's, as I said, an hemangioma or whatever. So don't be. I talk a lot to smoldering myeloma patients, to MGAS patients who bring me their results, and there is osteolysis in my MRI, which is not true because MRI does not show the bone, so there could not be an osteolysis in MRI. So this is the first one. So it's quite difficult. Look for focal lesion, look for diffuse infiltration, but do not get shocked when there is written something like this. Just ask your doctor, is it really a myeloma focal lesion or is it something else? Is it really diffuse infiltration by myeloma or is it something else?
And would a direct biopsy of something that's suspicious be the best way to, seal the deal to more or less determine if it is or not?
Yeah, it would be, but a lot of regions in the body you don't want to reach by a needle, and sometimes it's just better to do another MRI.
That's a good point.
Later.
Which regions would you avoid? Which regions would you not want to do that on?
Of course, the upper spine. Of course, the radiologists will not do it because they know it's too dangerous for the patient. Because the information you get out of it could be good, but it also could be worthless. So you would not put your patient, as a radiologist or a hematologist, will not put your patient in danger to get information you maybe can acquire by something else. To put a needle in if it's really suspicious, if something depends on it. If you would treat a patient because of this lesion alone, you should put a needle to confirm it's myeloma. If not, just repeat the MRI 3 or 6 months later because myeloma is not growing very fast in most cases. So you can just repeat the imaging, and if the lesion stays the same, it's not that malignant, of course. So we do the MRI in follow-up and see if there is a growth. Then we say, okay, it's malignant, there's growing, this is cancer. But if not, we just keep calm and try to tell the patient to be calm as well.
Okay. I know Dr. Landgreen has stated that osteolytic lesions are a complication of the disease in the marrow. So it makes so much sense to look at the marrow for the myeloma activity. Well, if the focal lesions or the diffuse infiltration is actually, for a smoldering patient, is actually related to myeloma, will this always lead to osteolytic bone lesions?
This is an excellent question, and I would love to answer it correctly. I don't know. We are doing a prospective trial at the moment where we put as many smoldering patients as possible into this study and doing an MRI every 6 months for years, as long as it takes.
Oh, wow.
And then we will see, and then if there is something, pain or something else going on, then we do a CT, and if there is an osteolysis, we will see. In several patients, over the years, I have seen some patients starting with a focal lesion in MRI, then going on and then developing an osteolysis. But this is just several patients. It's not research. It's not a study. But now we are doing a prospective study, and I know that Ola Landgren also does these studies, and we will see, I think in a few months or years, if this is true, if I think not every focal lesion will lead to an osteolysis, because at a certain point when you have the first osteolysis, you will treat the patient, and those focal lesions hopefully will not go on to become osteolysis. But we are looking into that, and it's a very, very important question.
Very good. Dr. Hillengass, are MRIs adequate for smoldering patients, or do we need to also have PET-CT scans or skeletal surveys? Say, for instance, we had a skeletal survey and it was clean, but we did get an MRI. Is that enough, or do we need to go on to that next test, PET-CT scan, to really rule out myeloma?
At the moment, there is no scientific paper out saying that PET-CT is beneficial for smoldering patients. So the information you get out of PET-CT, but you could think if a PET lesion is positive, and I know of some results, if there are PET-avid or PET-positive lesions in a smoldering patient, there seems to be some kind of activity. And if the only chance to get a CT for you is to have a PET-CT, I would recommend it, of course, because the CT part for the mineralized bone is very, very sensitive. So if you have a good CT from the PET-CT, you will still have additional information to the MRI, because, as I mentioned, in MRI you don't see the bone itself, just the bone marrow. So the first step for me would be an MRI, and if it's negative, maybe you don't need anything else. But on the other hand, some very small focal lesions are visible in CT and not in MRI. And this is the reason why we do, at the moment, CT plus MRI at first diagnosis. And then for follow-up to spare radiation dose, we do MRIs. Every once a year.
That sounds like a very good protocol. And skeletal surveys really are not very sensitive. From what I understand, you need to have 30 to 50% of cortical bone already destroyed before it picks it up. So a low-dose whole-body CT would make sense. And I think you did state that no contrast was needed for that, and it's 2 to 3 times more radiation than whole-body X-rays?
Correct.
Okay, but much more sensitive.
Yes.
Wonderful.
You get more information on stability, on the back part of the vertebral bodies, which are very important for stability, for neurological complications. We absolutely recommend low-dose CT, and at the moment we are working to change the guidelines in the International Myeloma Working Group to change from skeletal survey to low-dose CT.
Oh, yes, to make that the gold standard as opposed to the rusty standard of skeletal surveys. Yes. Now, Dr. Hillengass, do we need to have our MRIs with gadolinium contrast, or can we do these without GAD?
We can. Usually we do it without. If there is a suspicious lesion, maybe it could be helpful to use contrast, but it's not. In really absolutely most patients, it's not necessary to use gadolinium DTPA as a contrast agent in myeloma.
Provided you have a good radiology group who is familiar with the myeloma process and is actually reading and interpreting. Okay, so that makes sense as well.
Yeah.
As a smoldering patient, do we actually need whole body MRIs? They're very difficult to find. I mean, I haven't had one. I've only had MRIs of my full spine and my pelvis. Do I need a whole body MRI? Am I missing out on something?
Yeah, not very much. We have compared our whole body MRIs with spinal and pelvic MRI, as you get, and we found out that it was 100 patients, and in 10 of those 100 patients, we found it was symptomatic and smoldering mixed, and we found in 10 out of 100 patients that there were focal lesions outside the spine and pelvis. So 90% are inside spine and pelvis, and you also get this diffuse infiltration out of the information from the spine and pelvis. So if you only have access to spine and pelvis, it is okay. It's not very much that you miss when you don't do it as a whole body protocol.
Okay. Can you explain what diffusion-weighted imaging is? Is that a technique that is superior to if there is such a thing as a regular MRI? I'm not quite sure of the different technologies.
Yeah.
But I've heard about the diffusion-weighted imaging.
Yeah, very good. This is a very nice, it's just another sequence, another setting of the MRI scanner to get this diffusion-weighted imaging. You don't need contrast agent. It's just measuring the movement of water molecules in the tissue. And if you have a lot of cells, like high cellularity, like in myeloma, you have small ways those molecules can go, because there is a lot of cell membranes which are lipophilic, so-called, which are containing fat, and their water cannot mix with fat. So the diffusion-weighted imaging is based on this fact that water molecules cannot move that far if there are a lot of cells, and they can move with fewer cells, they couldn't move further. There are some pitfalls with the DWI, with this diffusion-weighted imaging, but we are working on this, and I know that other colleagues are also working on it. And I think it might be at least an additional technique, maybe in future, maybe even the only technique, because it is faster compared to conventional MRI, and it gets a higher contrast, because you have these focal lesions are very well visible. We do it in our whole body protocol as one part of the total protocol, and we get a lot of good information out of it. And the radiologists like it because it looks a little bit like a PET, and our radiologists call it the poor man's PET, because you just do it in the MRI, and you don't need contrast agent, you don't need PET tracer, and so it might be the technique of the future, but it can just be implemented into the MRI protocol. So it's just part of the MRI protocol.
Great, because my most recent one actually had that integrated into it, and I had never had one prior to it, so I was very happy to see that.
Yeah.
What about the combined PET MRI scanners that I've been hearing about? Is that the future?
I hope so. They're very fancy toys, of course. Radiologists love them. We as well, because you have this. No, really, the important thing is you have this high sensitivity for the diffuse infiltration I mentioned earlier from the MRI part, but you also get the information on vital cells, on disease activity, on metabolism from the PET part. So PET MRI is very rare. I know there are not very many scanners around the world at the moment. We have one, and the images are amazing. The problem is that you don't get information on the bone. So we are back to CT, low-dose CT,
that's right, because you don't then get,
Yeah. So this is a problem. We like the PET MRI very much, but we still do CT. So we can also do a PET CT and an MRI, or a PET MRI and a CT.
So we as patients are going to be stuck with CTs. Okay.
Right. Yes.
Okay. Well, that's too bad. That's too bad. I'm looking to eradicate the radiation as much as I can.
I know.
Dr. Hillengass, can you detect age-related osteoporosis via MRI, X-rays, or CT?
We cannot detect it. We can a little bit, to a certain degree, differentiate it. As I mentioned earlier, if you have a high cellularity, you will have a different display in the different image in the MRI. And this high cellularity meaning mostly malignant infiltration. And if a very low cellularity and a high fat content, which is normal in older patients, if you have a high fat content, then it's rather a benign cause of the osteoporosis. So you have, to a certain degree, you can differentiate between benign and malignant osteoporosis. It's not absolute. You cannot say always, if this is the case, it's always, but it's another information you can get, and then you do the bone marrow biopsy, you get the information on plasma cell content, you see the M spike and so on. And if you have the whole picture, MRI adds information. It's not the only, but it's an additional information.
Yeah, the whole picture is critical. I know sometimes we as patients focus on, the numbers and our charts and our trends, and we really need to just remember that it's a whole picture that really will push us into the treatment zone. Dr. Hillengass, I can't thank you enough for taking all of my questions. It really, truly has been a pleasure. My takeaway from this as a smoldering patient is that we deserve more advanced imaging than just skeletal surveys. And I encourage that within my own Facebook group to patients to push for that, because it's not easy for smoldering patients to really get adequate testing, especially within the community local settings. With the myeloma specialists, it's a different story. They know the emerging data, they know the emerging info, and they're willing to do that.
Of course, to modern imaging, of course. The big vendors have more scanners, have more scanning time.
Exactly.
More radiologists. This is it's not a bad will of the
exactly. It's no fault of their own. It's just the limitations, of their own practice, to not know and understand the nuances of this disease, as certainly you do. I mean, this is proof to hear someone like yourself discuss the imaging and to take the time to respond to all of my questions, my personal questions, as well as questions that I ask on behalf of the smoldering community. So I appreciate it very much, and I could probably spend another hour asking you more. I certainly don't want to use up all of Jenny's time. So with that, I thank you both very, very much for taking my question, and thank you, Dr. Hillengass, for doing this amazing work on behalf of all myeloma patients.
Thank you so much.
Yeah, thank you for your questions and for your answers. And we have just 5 more minutes before the show closes, but I do have several write-in questions. So one patient says, I was diagnosed with no lesions, so my doctor said I was the unlucky myeloma patient because my disease has progressed. So could I have diffuse lesions and not know it?
I can't answer this. You can have lesions without knowing it, of course, but I think the most important thing is that you can have myeloma without seeing lesions in MRI, because there's always a limitation of the sensitivity of those techniques. So if you don't see anything in bone marrow, in PET, in MRI, in cytogenetics, wherever, it's just a limitation of the technique. No technique is really absolute. Even in minimal residual disease measurement, there's no zero, of course. There's just a degree of depth of response, and the same is true for imaging. If you don't see lesions, it does not say they are not there. They might be too small, they might be too dim. So it could be that you have lesions. But on the other hand, we found in our patients where we just looked, that the radiologist didn't know if the patient had myeloma or smoldering or MGUS. They just looked at the image and said, okay, there is a focal lesion, or there's no focal lesion, or there's a number of focal lesions. And we found that if you don't see focal lesions, it's a good prognostic factor. Why is not clear. Maybe it's just because the tumor mass is low. You have been caught early in the course of the disease, and an early treatment might be beneficial. So this might be an answer to that. Yeah.
Well, she is lucky then. That's good.
Yeah, maybe. Hopefully.
The last question, and you may have covered some of this, but what are the minimum imaging requirements a newly diagnosed patient should request or demand from their doctors? That's our final question.
Yeah. So from the guidelines, it's at least an X-ray an X-ray plus an MRI, at least of the spine and pelvis, for the first diagnosis. Better than X-ray is CT, but this is not in the guidelines yet. It is now allowed to do a CT or a PET-CT to diagnose osteolysis, and you will find earlier or smaller osteolysis, of course, because of the higher sensitivity. So, but the guidelines at the moment say skeletal survey plus MRI of spine and pelvis at first diagnosis, and I think this is good. CT plus MRI of spine and pelvis is even better. CT plus whole body MRI is even more better, and a PET-CT is also very, very well. And I think it depends very much where you live, what the access is, what you can have. And so the minimal requirement is skeletal survey plus MRI of pelvis and spine.
Well, perfect. Well, Dr. Hillengass, we are so grateful that you took time to talk to us today. I think I'm going to go talk to my radiologist because of our conversation today and ask them to show me. I know, I'll give them some work to do. But I think it's so helpful for patients, especially newly diagnosed patients, to know what they should be asking for and why it matters. And you've explained that in really excellent ways. So we're just very, very grateful that you took the time. And we're very thankful that you have patience with our technology.
Thank you so much. It was my pleasure, my honor, and I like your work very much. I found your homepage before, or your website before we got in touch. But yeah, I like it very much. It's really, really important work you do, because we researchers cannot do anything without the help of the patients, because we have to examine patients to learn. And so you are also very, very helpful and very supportive. And I could have done no study at all without the help of my patients, and still are very grateful. I'm very grateful of all the patients who are willing to support the research. They have benefit, but we also have a benefit because we learn more about this disease. So thank you also.
Oh, well, we're just so happy that such smart people are working on this for us. And we're thankful that you've dedicated your life to multiple myeloma. We're just so intensely grateful for it. Anyway, we're just so thankful.
Thank you.
Well, thank you for listening to Myeloma Crowd Radio. We believe that patients can help accelerate the discovery of a cure, and we encourage you to become involved in part of that process.
With Lucky Land Slots, you can get lucky just about anywhere.
Dearly beloved, we are gathered here today to... Has anyone seen the bride and groom?
Sorry, we're here. We were getting lucky in the limo and we lost track of time.
No, Lucky Land Casino, with cash prizes that add up quicker than a guest registry.
in that case, I pronounce you lucky.
Play for free at LuckyLandSlots.com. Daily bonuses are waiting. No purchase necessary. Void where prohibited by law. 18+. Terms and conditions apply. See website for details.